This patient was a 46-year-old man with a history of GERD and BPH who presented on referral from an outside hospital for evaluation of small bowel polyposis. On upper endoscopy here, examination of the esophagus was notable for multiple white round nodules which were slightly raised with an almost confluent configuration, suggestive of diffuse glycogenic acanthosis. In the stomach, multiple round raised polyps were noted and can be seen here in the antrum, body, and fundus. Similarly, multiple 3 to 6 mm sessile polyps were distributed throughout the proximal small bowel, as seen here. In addition, the major and minor ampulla were nodular and polypoid. Multiple biopsies were taken. On pathologic examination, the biopsies from these esophageal lesions revealed hyperplastic glycogenated esophageal squamous mucosa consistent with glycogenic acanthosis. Biopsies from these stomach lesions revealed polypoid gastric antral mucosa with a lymphoid infiltrate and disorganized smooth muscle in the polyp core, potentially consistent with a hamartomatous polyp. From the perspective of the gastroenterologist, the presence of glycogenic acanthosis and hamartomatous polyps should suggest the diagnosis of Cowden's syndrome. Cowden's syndrome is an autosomal dominant condition also characterized by multiple cutaneous lesions, oral papillomatosis, macrocephaly, genitourinary tumors such as uterine fibroids, a high-arched palate, and most significantly in terms of outcome, benign and malignant disease of the thyroid and breast. This patient was seen in consultation by the genetics service and elected to undergo testing for an underlying germline mutation. Testing revealed a mutation in the P10 gene, confirming the diagnosis of Cowden's syndrome. The following screening recommendations were made: colonoscopy every 3 years, baseline and annual thyroid ultrasound, baseline and annual skin exam, monthly self with annual clinical breast exam, annual urinalysis, and a baseline MRI of the brain.